Hello and welcome to our November 2022 review of the latest lupus literature. I'm Ed Vital, I'm chair of the Lupus Forum and I'm an associate professor in Autoimmune Connective Tissue Diseases and an Honorary Consultant Rheumatologist at the University of Leeds in the UK. And I'm joined today by Professor Chris Edwards, who's a Consultant Rheumatologist and Honorary Chair of Clinical Rheumatology at University Hospital Southampton in the UK. Welcome, Chris.
Thanks, Ed. Good to be with you.
Yeah, good to see you again. So today we're going to review the key papers that are covered on the Lupus Forum from our literature searches of October and November. There's one thing we haven't included today, which is the phase 2 papers of litifilimab in SLE, which were published in New England Journal of Medicine. And the reason we haven't included those is there's a whole separate podcast of those with interviews with the two lead authors or elsewhere on the Lupus Forum that you can find it. That's one in SLE and one in CLE. So if you're interested in those, have a look at lupus-forum.com and you can find my interview with the lead authors, Professors Victoria Worth and Richard Fury. But let's make a start today with the others, and we're looking at a paper by Kandane Rathnayake et al. Chris, can you talk us through that one?
Yeah, no, I like looking at this particular slide, and it'll be interesting to look at the data now, so we can talk that through. And I was interested for a couple of reasons. There are some concepts in this. There are concepts around treat to target in lupus. There are concepts around what's low disease activity versus what's remission, and how important it is to aim for remission rather than low disease activity being good enough. And I think actually those are themes and concepts that are being discussed in other bits of inflammatory rheumatology as well at the moment. There's also, because of the population that's covered here, and I'll describe that in just a moment, there's also some discussion around low GDP countries and the effect that has on mortality, because this is about mortality in lupus. And there's a little bit around prednisolone dosing as well and how that may play into mortality as well. So this is an Asia-Pacific cohort. And if you look at the authors, there's representation from all the countries you can imagine, from Australia through Taiwan, through Singapore. And this population, particularly from Southeast Asia, some of these populations really have very bad lupus. So I'm always interested to look at this, having worked in Tan Tock Seng Hospital in Singapore in the past, and just having seen this population, the difficulties our colleagues have. So they looked at this particular group, they did some statistics, and they looked at the likelihood of achieving low disease activity, the lupus low disease activity score, LL-DAS, and they looked at the likelihood of achieving remission. And they related that to then mortality. So if you got into low disease activity, or if you got into remission, were you less likely to die in the period of follow-up that they had? And you can see that on the right-hand side of the slide, it shows this. And not surprisingly, getting into a low disease activity state was associated with less mortality. The same was true for remission, but actually low disease activity and remission were about the same. You didn't get much more extra by pushing even harder to get someone into remission. So as I said, concepts around lupus and treat to target, concepts around low disease activity versus remission. Very big population here of people with bad lupus, potentially in those populations, and then a bit about steroids and the effect of low GDP in a country on the mortality of individuals with lupus, which I think is important. I don't know, what did you think? Did you have any other thoughts about it?
I think this is going to go on being a hotter topic for a few reasons. I think I remember we looked maybe on the forum last year at a paper by Michelle Petrie's group, and they'd come to a similar conclusion that the more time you spent in low disease activity, the better for your long-term outcomes. Yep. But the low disease activity and remission were similarly good. So I guess this is quite coherent data that it's showing a similar thing. What else did I think? The other thing I thought about this one, and I think this is something we've said in some of our previous discussions, is everyone talks about the problems of lupus trials, high placebo response rates, difficult to reproduce the results from phase 2 to phase 3, things like that. And one thing I think data like this make me think is whether focusing on response all the time is necessarily the best thing to do with lupus. because lupus patients do go up and down a lot all the time. And when you do a trial that just tests response, like SRI-4 between 0 and 12 months, you're kind of ignoring everything that happens in between and just hitting the response.
So you're almost after a sort of an area under the curve concept.
Exactly. And that's what, exactly. So if these data are saying, well, that's a really important outcome to patients for long term, then maybe that's what the outcome in trials should be. And maybe we'll be a bit better. I think we've said, so that again, that fits with that. The one other thing I just thought, I was just thinking actually as you were talking just there, is as you say, there are some parts of the world where the lupus they see is worse than others. And it did make me think, well, that might mean it's harder to get LL-DAS, but it might also mean that the group who's not in LL-DAS are worse. And therefore that actually the benefits associated with LL-DAS are estimated at the high end here. If you do something where all the lupus is milder, then the better everyone might be closer to LL-DAS, and the difference in, generally I liked this, and I thought it's telling us a lot about the way.
Well, I think it's a great cohort, and it's lots of really smart people who are really good clinicians and who see really bad lupus, and so I'm always interested to see from this population. I suppose the only other statistical thing I wondered about, and I was trying to look at the paper and work it out, I suppose there are some statistical inevitabilities that, the longer you live, the longer you're likely to be in low disease activity. So some of the statistics of it is sort of inevitable. And I wanted something that said we've corrected for. And that's the one thing I couldn't see in it. So that's the only thing.
Want something like an inception cohort, don't you? Because otherwise they're more likely to be in this if they've had a certain outcome. That's right.
Exactly. There's a little bit of circularity in it, but even
and
so.
I think the other thing is that whilst I think we're both agreeing with this general concept of stay in low disease activity and keep it for longer, you might also question what LL-DAS is. So LL-DAS and remission both tested here, but so LL-DAS is mostly based on SLEDAI for the measure of disease activity.
Less than or equal to 4.
And the items are kind of on-off in SLEDAI, aren't they? So like mild arthritis and severe arthritis both count the same, mild rash and severe rash. So maybe you could have quite a nasty rash and still count as LL-DAS. That kind of thing. So, but I mean, the concept is absolutely correct. I think it's just we'll go on refining it, won't we?
I think so. But I'm also interested to know how hard to push. And I guess it plays to my the instinctive clinician in me is that push enough, but don't push too hard, so that it makes sense that you don't necessarily always have to aim for absolute remission. Low disease activity is often good enough. Okay, so should we move on to the next one, do you think?
Yeah, okay. So this one's by Howe and Fury et al., isn't it? And it's about belimumab.
Yeah, so we've got a couple. We've got the belimumab in lupus nephritis one coming up. We're going to start with the pregnancy one, and this is about a cohort that was put together to look for problems with pregnancy associated with belimumab, and it was set up a few years ago, and they've now followed. And it was mainly trying to be prospective, so you were looking at people that had this history of exposure and following them up over time. There's also a bit of retrospective data thrown in, and they were looking at major birth defects as the primary outcome, and then a whole list of different secondary outcome measures, as you can imagine: miscarriage, stillbirths, adverse infant outcomes in the first year of life. So a number of different things. And you can see it's data on the right hand side. So I guess the comment they made is they didn't end up with very many patients. It was a relatively small number, and I'm not quite sure where they got the estimate from, but they estimated that the accidental exposure to belimumab might be about 500 cases over this period of time, and therefore they're only getting about 10% of what they think they might. And that leads to a caveat, which is there are low recruitment numbers to this particular database. So it's a little bit harder to draw conclusions from it. And I guess we can always discuss whether if there's a problem, people are more likely to report things and therefore actually these 55 are the worst, or whether it's a general failure to recruit to this sort of registry. Maybe it also reflects people's views about biological therapies in general around pregnancy, and the fact that for other biologicals, we've become a bit more relaxed over the last 10 or 20 years because we haven't seen bad things happen.
Yeah.
But their headline was, there was no particular pattern of concern, as you'd expect with any pregnancy cohort. There are some pregnancy losses, but there didn't seem to be anything that was out of the ordinary or likely to be specific to belimumab, which I guess would fit with the mechanism of action. I mean, we know from animal studies that it crosses the placenta. We know that you would get something into a neonate. But, it's for all it's limited, it's reassuring, I think.
I mean, yeah, with monoclonals, I think the placental transfer is more later in pregnancy, isn't it?
Yes. Yeah.
So that's one reason why things often work out a bit better is you're pregnant and you need to stop the drug before you get into those risk phases. The other thing that's been mentioned when similar work was done with rituximab was that, people looked at exactly the same thing, and if rituximab is given a bit later in pregnancy, it absolutely can cause B-cell depletion in the fetus. But then people questioned how bad is that? Because it is very specifically affecting B cells and not anything else, and fetuses don't have mature B cells when they're born. So that's probably, I mean, this is all completely speculative. I suppose the real clinical message from this is, would it be fair to say, is that you can't from these data say belimumab's safe to use in pregnancy because you just haven't got the numbers and exposure there. But what you might say is that if it does happen accidentally, then your level of concern is a bit lower than it.
I think so. I mean, the story around these things is, there's toxicology data, then there's long-term use, then there's this sort of information, and bit by bit, we establish that. So this is like building a jigsaw, and this is another piece, which is reassuring. It makes the picture clearer, doesn't it? But it doesn't answer it. And I sort of plays in my mind if I think about the obstetricians who look after our high-risk pregnancy clinics and their views of these things. Their view would also be very strongly, where people have really bad disease, you need to treat the lupus, because if you don't, pregnancy will definitely be bad, versus a risk, certainly I think for most of the biological therapies, more of a theoretical risk. And as you've already highlighted, we can't say it's safe because people have different views on it. I mean, I think if you look around the world, I think in the US, people still say avoid belimumab in pregnancy in that wording. I think for EULAR and a UK type setting, people would say, be careful. So the language used is slightly different, but anyway, more data. So maybe we should move on to the next one.
Okay,
Yeah. Okay, so the next one is it's an add-on study, if you like. This is a longer term extension type study to a study that we already know well, which is a Bliss lupus nephritis study with Richard Furey as the first author, as he was on that original New England Journal of Medicine paper. And so these people were followed out originally in the study to 104 weeks. And of course, this showed efficacy in a couple of different renal outcomes, the partial and complete renal responses. And then they followed them for another 28 weeks. And at this stage, of course, these people are all now taking belimumab. So they were either originally on belimumab and they carried on with belimumab, or they were on placebo and they switched over to belimumab with, of course, all their background therapies as well. And so there's data from this that is about efficacy. Did it continue to work? And there's also information here about adverse events. And I spent a bit of time on the paper just looking through adverse events to see whether there was anything that popped up as being particularly different that comes out of this longer follow-up. And there wasn't really anything that I could see. Over on the right-hand side of the slide, we've got the primary endpoint, which was the adverse events and the different numbers of those over time. And they also tried to divide. I don't know how useful this is, but often in studies, people will look at the difference between people who were on the placebo and switched to the active drug belimumab versus those that stayed on. And there are always little differences as people kind of crunch into whatever effect the newer therapy will have. I'm not sure that showed very much difference, but for me, what it showed was that efficacy was maintained, so that's great. And adverse events, nothing new that popped up. And I guess we'll get more and more bits of data from this over time and bits of post hoc analysis as well.
Yeah, I mean, the problem always with these long-term extensions, isn't it, is that you lose the placebo arm usually. And so the people who remain in the long-term extension were doing okay, because if you'd got a problem, probably would have dropped out and done something else. So you don't you never really know exactly how things went, including everybody. maybe if you analysed it in a different way, you might. But still, I think it's I think it ties with some of the things we've seen about belimumab. So we were looking at the ACR data, and there was a safety analysis done in real world data. Yep. Where they compared belimumab to various other conventional therapies for lupus with adjusting for covariates, and concluded that actually the serious adverse event rates were a bit lower with belimumab than some of the other therapies we use. And I thought that was quite reassuring, and that ties in very well here, doesn't it?
Yeah. And I think you using the word reassure, I think it files in the reassuring file, doesn't it? That's where it goes. It's not earth-shattering. It doesn't tell you completely new stuff. It just says, yeah, okay, carry on as before. This is going along okay.
I mean, there's always this question, isn't there, in lupus nephritis, that the standard of care has always been at induction, you need lots of therapies and to be quite aggressive and intensive, because that's when it's all very active and lots of damage can occur. But then as time goes out, you might taper things down, and you never know exactly how long that needs. How long do you need your combination therapy for? And if you taper down to mycophenolate alone, how long do you need that for? And I think that those are all be.
Yeah, and then also the balance of when you can take away your steroids, if ever you do, I've been trained by people over many years to reduce steroids as much as I possibly can, but with life or organ threatening lupus, to leave that last 3 milligrams behind. If we're going to use biological therapies more regularly in the long term, maybe I can take that last bit of steroid away safely. So it sort of becomes a choice about what you take away as well.
Okay, so I had a look at this paper by Mackinson et al., and this is about CAR T-cell therapy. So this is something that's generated quite a lot of buzz at EULAR, and it's a paper in Nature Medicine, and we don't see many of those. So it's interesting. It's also a paper with only 5 patients being treated in it. So why do 5 patients generate so much interest and such a high-profile publication? So it's because the therapy they gave was pretty novel. And this is about targeting B cells. And we've been doing that for about 20 years using rituximab. But it's doing it in a different way that hypothetically may work better. So what they essentially do is, so when we use rituximab, we're using a monoclonal antibody that targets CD20, and CD20 is expressed on mature B cells. And actually, the rituximab doesn't kill the B cells themselves. So rituximab binding to the B cell, that doesn't make the B cell die. It dies because some other effector mechanisms come in, like NK cells and monocytes and complement and things like that kill the B cell. It seems like in lupus, particularly in all diseases, but in lupus particularly, that killing of the B cells with the rituximab actually isn't quite as complete as we first thought, and maybe not quite as complete as we need it to be. So it's this was partly one thing I did in my PhD, was showing that if B cell depletion wasn't quite as deep, then the patients didn't respond as well or for as long. And maybe that even though B cells might go in the circulation, they may still be there in tissues. And so there's been interest in how to kill them more effectively. Some of the other things we've reviewed over the past year or so, like combining rituximab with belimumab to try and keep their numbers down, or obinutuzumab that's meant to be a more potent monoclonal antibody. But this is an approach that's come from oncology, which is, instead of using a monoclonal antibody, what you do is you take the patient's own T cells, they get reprogrammed so that instead of expressing their natural T cell receptor that determines what they're specific for, they express an anti-CD19, and then you return them to the patients, and those T cells then go around killing B cells. And that may be a more effective way of killing B cells, particularly when you've got to get into other tissues. And it may bypass some of the problems that stops B cell killing with rituximab. It's also CD19 rather than CD20. Most B cells express both of those, But as you get later into the B cell differentiation, as they're going from B cells into plasma cells, you get more CD19 expression when CD20 starts disappearing. So that might be another reason. So what they report here is so complex and expensive, and that's generated a lot of discussion as well. But what they report here is they took 5 patients who had pretty bad lupus. They gave them this therapy, and all 5 of them got into DORIS remission after 3 months. And that was maintained for something like 18 months. And in particular, they note that the remission seemed very good quality in that patients were getting normalization of their autoantibodies and coming off their conventional therapies. So generally, so that's why it generated a lot of excitement. Is this really the immune reset that we always had been looking for? Is this getting closer to a cure for lupus?
Yeah, and I thought, yeah, so fascinating. It's sort of separating it in my mind. So anything that uses a therapy like this, a cancer therapy that's newer and aggressive is always going to attract attention. Yeah. It's a bit like some of the attention that's, maybe stem cell transplants for scleroderma got. It was a very bold, aggressive thing to do. You could imagine there might be a small group of people who would respond to it. But you've raised this already. You just wonder how much lower are the B cells? How much deeper is the depletion? How much extra do you get? And then the bit around, if you have T cells binding to B cells, helping to destroy them, is that a better mechanism of action than having an antibody that then, through natural killer cells and other mechanisms, destroy the B cells? And it's, I guess we don't know the answer of that yet. Do you get more than just getting rid of B cells in a different way?
Yeah, so this is one reason I really started to think about this. So I was speaking at David Eisenberg's Festschrift a couple of months ago. And so I was reviewing some of his old papers. And back in, I think is it 2002, 2003, something like that. So I know it's almost 20 years ago. There was his first report of using rituximab to deplete B cells in SLE. And what he said in that paper was, I treated 5 patients, I depleted their B cells, and I got 18 months remission. Isn't this amazing? So this is why, then what it made me think is, well, okay, so what is different here? And I do believe there may be something very different about this approach. There is a good precedent to say this will deplete B cells more deeply and in a more long-lasting way, and that will be better. But that hasn't actually been shown yet, I think. That's the skepticism in my mind, is like, I'm excited, but I want to show me that it's different from rituximab. So either, of course, there's no comparator here because you just wouldn't do that at such an early stage of development. But these patients hadn't failed rituximab before, which would have been interesting. If they'd already had rituximab, that hadn't worked, but then this did the job. Or show me that it's longer lasting,
and then I suppose more people for the adverse events that we see with CAR T cell therapies for the cancer patients, and then if you get an episode of some sort of adverse event as a result of overzealous T cells, what that looks like in someone who already has an autoimmune disease rather than a cancer, and whether that's better, worse, I don't know. You can hypothesize that it could be either, but I guess that needs more numbers, doesn't it, to understand that?
Yeah, that's right. And I also, this is going to lead into the next paper that we're going to discuss. Is I have a slightly more conceptual concern about the hypothesis here. They may be completely right, but I think there is a counter hypothesis. So what this is basically assuming, when you talk about trying to do an immune reset that would cure lupus, what you're basically assuming is that initially your immune system was normal, and then at some point in adolescence or early middle age where you develop lupus, what happened is your B cells and T cells, these decision-making cells, made a mistake and decided to target an autoantigen. And then, of course, because that selects for them to survive, then that mistake gets continued. Once they get feedback that they are hitting that antigen, B cells and T cells survive and proliferate, and it becomes out of control. And therefore, that if you could just reset it, you could put it back to that earlier state of affairs, and that's cure. And that is an exciting idea. But I think there's another side to this story, and this is the next paper that we're going to discuss. So this is a review article, and it's my review article, but it's about type 1 interferons. So all of that B-cell directed theory is all based on adaptive immunity and targeting adaptive immunity. But all this data about type 1 interferons, the genetics around it, the therapies of it, the functional experiments, that's all. We're all talking about innate immunity here. Yeah. And since it's got a strong genetic basis, that's probably something that could exist in patients, whatever you do to their B cells. And what we've discussed a few things in this review. We discussed things like the interferon biomarkers and the therapies, but particularly importantly, what we review is some data on where does interferon come from and why. And what we found is that there was the idea that interferons come from circulating immune cells maybe is not right, that there isn't actually so much production of interferon by the blood. But what there is instead, and even before the onset of lupus, is production of interferons by all the different organs that are affected by lupus. Not immune cells in the organs, by the organs themselves. So in the skin, keratinocytes, in the kidney, the tubular epithelial cells, and so on. And so what that's sort of saying is if you think about lupus as being a disease where immune cells out of the blood go and attack healthy tissues, well, this is saying, well, that's not the whole story, actually. There's another side of this, which is the tissues themselves saying to the blood immune cells, come and attack me. Yeah. And I think the reason I got excited about this and why we wrote the review is I sort of thought, well, that might answer a lot of things we never knew about lupus. Like, why has this person got a rash? This person got kidney involvement and this person got joint involvement when everything in their blood looks exactly the same. Well, maybe there's another side to the disease that's coming from those organs.
Yeah. So it's the target organs themselves rather than the immune cells seeking out the tissue and making the decision. The decision is preset by the organ itself and the resident. Well, yeah, and some of those stories have been around, and with other inflammatory diseases and autoimmune disease for years, and the importance of the stromal cells, the importance of the fibroblasts, the tissue-related cells and their specificity that are already there. And just spinning off ideas, it also makes you start to think about therapies that then are targeted to end up in the area where there's inflammation in the tissues. I don't know, for rheumatoid.
Yeah, exactly that. It's like, does this tell us something about why some patients are resistant to therapies?
Yeah.
And therefore what we should do instead? Because if you think, so like like blood immune cells, they regulate themselves, don't they? Yep. Every cell does it. If it's going to make interferon, whatever it does, there's always a feedback mechanism that switches it off again, because otherwise we'd get sepsis all the time. But if you take something like the keratinocytes in the skin that are making their interferons in response to UV light, that's a barrier organ. That's different. You don't want that to regulate itself. You want it to keep doing it every time it gets the environmental stimulus. So that's why you get sustained interferon production, because the tissue that's doing it is not made to be regulated, made to keep going. And of course, keratinocytes in the skin do not care about azathioprine or belimumab or targeting B cells or anything else.
So then we need some sort of bivalent therapy that targets to the tissue, to the keratinocyte in the example you just gave, and then has a bit of anti-interferon attached to it.
Maybe, but there's certainly there are some drug targets out there, I think, that we've never even thought about, because we don't think they're in the immune system.
Okay, that's the point.
So that's why I question whether just depleting B cells is going to really cure everything, because I think the disease is in every cell. It's in the soil. You can't just cure it with a quick reset of your B cell compartment. So on that thought, I think that wraps up our review of the literature from October and November. So thanks, Chris, for your insights today.
Thank you, Ed. Good to join you.
And thank you everyone for listening. All the papers that we've discussed today are available on the website. You can find them on lupus-forum.com. And we regularly update that with publication podcasts like this one, but also author interviews, Congress reviews. We just did the ACR 2022. So if you make sure you're registered, you'll get updates whenever new content becomes available. And you can also follow us on Lupus Forum, all one word, on Twitter and LinkedIn. So thanks again, and see you next time.